So good afternoon, everyone. And I thank the WeCare team for inviting me here. And when Dr. Shaila actually called me for this topic, I was first thinking for a few days what exactly she wants me to talk on. Then I thought that obviously if we talk about what's new in therapeutics, and obviously as of now we are focusing on diabetes. So when we say what's new in therapeutics, there's so much new. If you search the literature, you'll get so many things. So what I have done is I have tried to put it into few of the things. Like first we need to understand what is therapeutics, because when she told what's new in therapeutics, then first I went and found out that what exactly is the definition of therapeutics. So it is actually serving and caring for the patient in a comprehensive manner, preventing the disease as well as managing the specific problems. So it starts from the time the patient is looking for a doctor, goes to the doctor, that also, to the time when you are treating and whatever the drugs. So it's a huge, huge thing. So obviously I cannot go into all the details in the next 15 minutes. So we'll try to see what are the major things which has come up recently in the past 1 year or so, and what new things we have understood regarding the management of diabetes. Now, Dr. Julka already talked about the 100 years of insulin discovery, and we know that now we have more and more newer insulin molecules coming up. So I'll be touching that as well, but also I'll be talking about few other things which have come up recently. So I'll be just talking on these points, like what new we have understood in the management of diabetes, what are the new technology innovations, the drug therapy, and little bit on the gut microbiota. So just to start with, we all know that we always used to talk about that diabetes management is not one, like everybody cannot be treated as same. It has to be an individualized management, and that's what we know. And now we are going more towards it. So this has been the conventional teaching, not that we didn't know about it, we knew about it, but now we are more into it and we have understood it better. So now we know that there are a lot of other factors. We have cluster classification of diabetes, we have different ways of classification, and we know that we can manage our specific patient accordingly. We don't have a pointer, right? Pointer? Okay, fine, I'll do that, yeah. So, I'll do that, yeah. So yeah, pointer options are there, yeah. Okay, fine, I got it, yeah, thank you. So now we know that when we talk about the precision medicine, we know that now we have so many things with the genetics which we can do. We know we already had this available, but now more and more avenues are opening up for patients to get it done. We can do risk prediction. Now we can do a better risk prediction. We have so many calculators. We have other ways of doing the risk prediction. We can also have an idea that which patient will respond to which drug better. So those type of things can be done now, and we have more better knowledge about it. Now coming to the technology, now technology is always good, but it has to be taken that when the patient is able to also comply with that. Like we cannot start advising CGM to all our patients from tomorrow, or we cannot tell that all our patients need to have an app on the phone, because some patients may be able to do it, but some patients may not be able to do it. But technology has definitely proven to be beneficial not only for the glycemic control, but also for the reduction of hypoglycemia. And not only for that, but all this translates into improvement in the quality of life. So we have multiple things, newer things available, like we have the CGMs, which is easily available to our patients. We have the closed loop insulin pumps, which are now available. And we also have the smart insulin pens. So we have different types of innovations which have come up, because many times it happens the patients have dementia, or they have not exactly dementia, but they have a little bit of a cognitive decline, and they don't remember that they have taken the insulin. So now we have smart pens where through the phone app, the patient can see that what was the last dose of insulin which was injected, and whether the patient took that much dose or patient hasn't taken, so patient can see and then inject. Patient can also get an idea about the dose which is required for a particular meal. So that applications and those type of apps are now also available, though not very easily. So now we also have the options of connected CGM and insulin pumps and the artificial pancreas. We all know that we have now a closed loop sort of an insulin delivery where the patient's glucose values are being transmitted, and then according to that there is an insulin dose which is adjusted, and the patient can get that insulin dose. The patient doesn't have to do the adjustment in between. So this is what we call as a closed loop. So we are also working along with ISC or for a similar type of a closed loop system in Bangalore as well. But this is what is the new, and it is available. Internationally, yes, there is availability of that, and we have these type of insulin pumps. Not to forget that when we talk about diabetes management or new in therapeutics, diabetes educators have come up in a big way. Because now we know that the main problem in diabetes management is not that the doctor is not aware or the doctor is not doing the right thing. The problem is also that the patient is not aware what to do. So many a times we write the best of insulins for the patient, but the technique or the methodology is not right, and the patient has not been told about what has to be done. So now more and more thrust is being put on having the trained diabetes educators as well as using the smartphone apps for these things. Now, talking about little bit about the automated insulin delivery. Now we know that that is definitely a good thing, and there are some studies which have been done, and they have found that it has been found to be better not only with regards to the control of the glucose values, but also with regards to hypoglycemia. The hypoglycemia incidence was less, and also they did find that more of the time was spent in range. So patient had more time during the day in the normal range which the patient was expected to be. Now, Dr. Julka was nicely talking about 100 years of insulin, and he has given me this task to talk about the future. So I'll be telling a little bit about the newer insulins which are in the pipeline, you can say. So once weekly insulin, which is being now studied, and studies are available now with that. We know that now we have an insulin icodec, which is an analog acylated with a diacid fatty side chain, and this can act for a longer period. So it's a once weekly insulin, and they have tried to compare it with insulin glargine, and they did find that it was comparable to insulin glargine, though it looked a little bit better. But what the final result was that it was comparable to insulin glargine with regards to the hypoglycemia incidence, with regards to the weight gain, with regards to the HbA1c reduction, and also with regards to the number of patients who could achieve a HbA1c target of below 7. Basal weekly insulin is another one which is coming up, is the fusion protein, which is a single chain insulin variant with a human immunoglobulin G fragment crystallizable domain. This is by Eli Lilly. This is also being studied, and this has been found to actually have a 100-fold selectivity versus the IGF-1 receptor, and this actually leads to a glucose lowering effect for up to 10 days. So as of now, this is also being studied. So this is another basal insulin apart from icodec. Icodec has almost reached the phase 3, but this is another one which is being developed by Eli Lilly, and this is even longer acting up to 10 days. And we all know about the ultra-rapid Lispro, which has been studied well and has been found to have a very good effect not only on the 2 hours postprandial glucose values, but also to maintain the normal physiological values as compared to a non-diabetic person. So this actually, the half maximal drug concentrations reached after 13 minutes, and the studies have shown that the glucose, the values within the 2 hours were almost equal to the physiological levels expected for a non-diabetic patient as well. So this also has been approved, and it is available as 100 IU per ml, not in India, but internationally by FDA it has been approved, and 200 IU per ml. Another thing which all of us are a little bit aware about is tirzepatide. We know that is the twin cretin. We call about it like it is because it targets both the GLP-1 and the GIP. So it is a dual agonist, and this has been found to improve the glycemic control. The HbA1c reduction was seen to the tune of around 1.6% in the studies as well, and it has been found to also help in weight loss. So it has been approved for obesity as well as for weight loss, as well as for diabetes. So two indications are there. So this was the study which was published in NEGM, where the HbA1c drop was actually seen 2%, and with the different doses, and they tried a dose of 5, 10, or 15. This is a once weekly therapy. Now, this was a very interesting study where they tried to see what is the choice of the second therapy. Now, if you have a patient who is a low cardiovascular risk, because we always say we can add anything. So they tried to see, but only flaw of this study is that time the SGLT2 were not included. So amongst the second therapy, apart from the SGLT2, they came to the conclusion that liraglutide performed the best with regards to the further beneficial effect on the cardiovascular outcome. But only thing in this study is SGLT2 were not there at the start, so they have not included that in the analysis. Now, always we say that if a patient is older, they may not need so much of lifestyle modification, but this was a very good study which came recently, where they have clearly shown that even in older people, if you advise lifestyle modification, they found a better reduction of the HbA1c as well as the body weight they did see more hypoglycemia than the control interventions, but they were not severe enough. So they concluded that even in older adults, it's good to advise lifestyle modification. Now, few of the newer things which are associated with the comorbidities. So if you see, now ADA is almost in sync with AHA and ACC guidelines for the blood pressure control of below 130/80 for patients with diabetes, because previously they had different cutoffs, but now they are very clear, and they are almost in sync with the other guidelines as well. We always see our patients suffering with neuropathy, and we don't know really what to do. So now the latest is, as per this Lancet article, they have tried to see that combination therapies are the best treatment for a patient who is not responding to monotherapy. Because normally what we do is we go on increasing the dose of a single therapy. Like we say in diabetes, it's good to target multiple pathophysiology. Similarly, now in painful diabetic neuropathy, they have found that if we add on the second drug, that can actually give a better pain relief as compared to the escalation of a single drug which is being used and the patient is not responding to that in the dose which you are using the drug. Finerenone, all of us must have attended so many talks on this. We know that now finerenone is also approved after SGLT2 in patients who have increased albuminuria and who have type 2. So these are little bit things which we need to know about diabetes management and the comorbidities. Now the talk of everywhere, when we talk about diabetes, we don't close the topic without talking about nutrition and diabetes remission. So we know that this is now a very, very interesting thing which everybody is talking about, and we know that this is something which is there, but it has to be done scientifically. So we know that there is a hypothesis behind that. We know that with the remission which is achieved by weight loss, there is a reduction in the liver fat, there's a reduction in the pancreatic fat, and an improvement in the beta cell function which persists. But we also have to understand that this is mostly the weight loss which takes care of that and has to be maintained. So whatever studies have been done, they have found that even after that, they have seen in further follow-up of these patients, there was a lesser pancreatic fat as well as the liver fat, even on follow-up. And we also have to remember that the patient has to be counseled to maintain the lifestyle, because if the patient stops and regains the weight, the things may come back to the normal or the previous situation. Also, we need to understand that even the patients who go into remission, it has been seen that their chances of getting diabetes complications are higher as compared to a non-diabetic. So they need to be followed as we are following a type 2 diabetes for the complications. So this was direct trial, which we are all aware of. So what information we have got is less than 10 years of diabetes, we should or we can think of these possibilities. More than 10 years of diabetes, though in the direct trial, they did not find that diabetes duration was related to that, but they were diabetic for less than 6 years only. Now, another very interesting thing has come up is the verapamil, which has been found to be beneficial both in type 2 and type 1 patients for the prevention of the decline of the beta cell function. And this is a very, very interesting thing which has come off late, and we all know verapamil is very easily available, though not that we start using it from tomorrow, but it has been now studied and studies are coming up. So this was the exploratory study which they tried to see the systemic and the cellular effects of verapamil in type 1, and they did find that it delayed the type 1 diabetes progression. It also promoted the endogenous beta cell function, and it also lowered the insulin requirement. And they took children only whose weight was more than 30 kg. This was another study where they did a RCT. Again, they have taken patients whose weight was more than 30 kg, and they went up to a maximum dose of 360 milligrams per day. And they did find that it did partially preserve the C-peptide till the 52 weeks. So that is a very interesting data which is coming up, which is as of just February 24, 2023, this study has come up. So this is another new thing which we are coming to know, maybe because it's a cheaper drug. It's very easy. So another thing which is approved is teplizumab. We know that is a CD23 monoclonal antibody which has been approved for the stage 3 of type 1, because patients who are already in stage 2 can be put on this, and it is a single 14-day course which has been found to delay the diagnosis of type 1 by at least a median of 2 years. So that's one thing which has come up. No talk on diabetes, newer things is complete without gut microbiota. So this is another study which has come up recently, not that this is the only study. We have thousands of data on gut microbiota, and it has been seen that like patients who are responding to GLP-1s in one manner or the other, there may be a difference in the gut microbiota of these patients. So that's That's the new thing which has been studied in this study, because we know that gut microbiota are related to inflammation, are related to hyperglycemia and progression of diabetes. But in this study, they have tried to see the varied responses of the GLP-1 receptor agonist in type 2, because we know that in Asians and versus Caucasians, there's a differential response with DPP-4, with GLP-1. But this is another thing which they have found out now. So maybe there is a difference in the gut microbiota, which may be the difference rather than the other factors which we discuss most of the times. So what we have learned in these past 15 minutes is that we have the newer insulins like the icodec. As I told you, there's another longer acting coming from the Eli Lilly as well. And we also have an ultra rapid acting, or the ultra very, very short acting insulin which is there. And these insulins will definitely change the future management, because just now before the talk we were discussing that a lot of times type 1 diabetes patients default with the treatment because of the number of pricks. So if we have something like a once weekly basal, which can be very helpful with the prandial, obviously, which has to be given alongside. And with these newer delivery systems, it is becoming much and much easier, especially with the closed loop, which has definitely shown a better glycemic control in many of the patients, and with the adequate use of technology. Now patients can have a plate and they can just put their app on and they can actually get how much are the calories, what is the carb count, and they don't have to actually calculate, because it is very difficult for sometimes the patients to understand this. And not to forget that lifestyle is for all ages. It's not only for young, it's for everybody. So even if a patient is old, they also have to be advised lifestyle, and we have evidence for that. So it's not that we are talking this without evidence. Remission is something, yes, but it has to be done scientifically. Not that a patient who is on a insulin dose which is 100 units per day and a patient is having diabetes for 20 years, we promise remission. Most of the studies have taken less than 10 years in the direct trial, though they did not see the relation with the duration, but the average duration was 6 years or less. So we have to understand that all these things are in the pipeline, and including the gut microbiota, which is one of the latest things which people are trying. Even the implantation of the fecal matters to see different gut microbiota which can be put into the patient to make their inflammation lesser. So these are all the things which are coming up in the pipeline. I know there are many more things which is there in the therapeutics. It doesn't end here. But I thought in these 15 minutes, if we know these things, and not to forget the latest data which has come up with verapamil for both type 1 and type 2, which is very, very interesting. So if anybody is interested, you can all go and read this article, which was just published. And it's a very nice article where they have talked about how verapamil helps both in type 1 and type 2 for the beta cell loss prevention. So that's another good thing, or because it's such a very cheap drug, and cheap drug in the sense when we talk about monoclonal antibodies compared to that, this is a much easier option. So hopefully maybe next year we will have some better options available for our patients. Thank you.